introduce our own Dave Wilkin next to draw all this together for us. So Dave's the COO here at the Chief Operating Officer at OCAL, and he began representing injured workers in 1990 as a member of the Advocates for Injured Workers Student Legal Clinic, later serving for 6 years as the clinic's primary legal supervisor. So he's worked for Injured Workers Consultants, the Office of the Worker Advisor, the Industrial Accident Victims Group of Ontario, IAVCO from 1994 to 2009, and the Building Trades Workers Service, a nonprofit association of local unions. So he's currently, again, as I mentioned, our Chief Operating Officer here at OCAL, which is he's going to tell us more about our interdisciplinary team and dovetail it into our last few speakers and show how, you know, science and evidence are important and workers concerned about work-related health conditions, workers, unions, employers who need support to prevent these health conditions from developing. So he's, without further ado, Dave.
So I wanted to talk a bit about OCAL's clinical approach in general as the context for the sorts of things that Sarah was talking about, what we're trying to achieve, and what it contributes overall to the understanding of occupational disease and of some of these rare conditions. Clinical medicine, as opposed to medical academic research, is defined by interaction with, observation, examination, and treatment of individual patients. And occupational medicine itself is grounded in this, and but incorporates a lot of public health considerations, was first in line for evidence-based medicine in terms of making use of epidemiological studies, incorporating population-level insights into approaching these sorts of questions. And so looking at workers in an industry, in an entire workplace, and also at environmental effects on the general population outside of the workplaces. So it, you know, like with your family doctor, it's tackling the health issues brought forward by patients, and then looking at the possible involvement of work and hoping to improve treatment, which OCAL is not involved in, other than making some identifications that might be useful to outside treating physicians, and for prevention, which we very much are involved in. First father of occupational medicine, Bernardino Ramazzini, exemplifies this approach. So he added to the questions that Hippocrates said every physician should ask a patient in terms of intaking the patient, gathering information, said you should also ask, what is your occupation? It was pointed out earlier that people spend most of their waking hours at work, involved in work exposure as well. Back in the 1600s and 1700s, that was even more so. But Ramazzini also combined that with the direct observation in workplaces of the exposures, both from a hygiene point of view and an ergonomic point of view. You know, what were the dusts, chemicals, the motions, the postures, et cetera, and then set out to identify the conditions that were characteristic of specific occupations. And that formulation was part of the initial definition of an occupational disease legally in a lot of jurisdictions, including ours. But of course, we now understand that there are many conditions that are not confined to those specific exposures, that have multiple causes from various occupations and from everyday life. And part of the work that we do when we're seeing individual patients is trying to tease those apart, again, using the best available epidemiological information. The clinical approach was also very important in the initial recognition of occupational cancers. So a pioneer in this field was Wilhelm Hooper, And he's interested, and I mention him just because he published the first book on this topic of occupational cancer in the 40s, but also because he exemplified some of the other things that are very important that particularly people involved in policy work or legal work need to be concerned about when approaching any medical scientific evidence. So he was the first director of the environmental cancer section at the National Cancer Institute, published a pamphlet there in 1950 on carcinogens, environmental carcinogens, that warned about asbestos as being carcinogenic, and was also a sort of a pioneer in showing how your work gets suppressed potentially by industry and government if they don't like what you're doing. So before he was at the NCI, he also worked at an industrial toxicology lab that was funded by DuPont, and he also identified a bladder carcinogen and began putting this information out. But unfortunately, for its further distribution, it was a DuPont product. And they not only worked to suppress that particular work at that time, but sort of then shadowed him for the rest of his career, trying to make his life difficult. And he was also a pioneer in pointing out the dangers of modern epidemiology in the context of occupational medicine and making determinations regarding occupational cancers. So as an example, and, it's possible, of course, to go on at great length and to categorize a lot of these. But, at that time, when modern epidemiology was first being born, in the 1950s, especially with the work on cigarette smoking, it was much more clear than it is to the average person even than it is today that, for example, statistical significance is a made-up number. It was sort of discussed, debated, ultimately had a sort of consensus to use the 95% confidence interval. But if you're using that, as it has sometimes been done inappropriately in a legal context, to just say, well, this study is worthless because it's not statistically significant, you have that. But he also recognized very much the importance of clinical medicine and pathology in determining which cancers were occupationally related. I'll come back to that in a little bit. That is something that also had a greater role in our legal system here at the Appeals Tribunal years ago than it does now. So OCAL's approach also, as the name implies, has from the beginning been clinical, both in this sense of trying to tackle the problems that are brought to us by patients. So we're founded by the Steelworkers local at Stelco and Hamilton, together with physicians from the McMaster University Occupational Health Program, precisely to give support to the workers in that plant in interpreting hygiene data and so on, so that they would be able to go into their discussions and battles with their employer well armed. And then since then, with the assistance of the OFL, we became established as a bigger system, and the other various unions that now have 7 clinics and are continuing to work, to be designed as a group that provides the answers to workers and worker organizations when they come to us with questions. Our OCDisease work incorporates a number of these different types of services. Primarily, we have the medical diagnostic service, so looking at a health condition, trying to determine if there's work involvement with it and the significance of that, and a group service. So again, this is primarily from workers. We demand worker involvement when something is brought to us. So it could be an individual worker, a union, or a joint health and safety committee that also includes the employer representatives, but we don't work without the full involvement of the worker or workers who are there. And then we have our multidisciplinary team. So, and again, this is meant to incorporate all those different aspects that go all the way back to Ramazzini. So physicians, nurses, hygienists, ergonomists, and then the various supporting roles. So the Occupational Disease Intake Clinic, and this is where the rubber hits the road on these projects looking at industries or workplaces. And you'll see here a picture from 2016, first week of October, I believe, at the Steelworkers Hall in Sudbury, where when we were still able to do these things in person. It's an open process where we try to schedule people into sort of a large window to just come and to speak to OCAL staff or volunteers from different unions, legal clinics, and so on, in order to gather information. So we start off with this request about a suspected or perceived cluster of occupational disease in some cases, but also as exit clinics. If a factory is shutting down or a mine, to document the health status and the exposures of the individual workers on the plant closing. And as time has gone on, we've gotten much more into also collecting general information regarding that workplace and making sure that that gets appropriately preserved. So at an event like that, it would start off with a sort of orientation for the workers or family members of deceased workers who are attending, register them, get their healthcare consents, and then take down the health histories and health conditions, work histories, and exposures, et cetera, and gather that historical information about the plant in general. So we've been working over the last 2 years to make this a more effective process when done remotely. So continuing our intake on Max Powder workers, General Electric, the plastics plant, the Dryden paper mill construction project, the Nylon casting foundry in Sudbury, et cetera. And, it's a very labor-intensive process, this. Some of the health interviews can take up to 2 hours, exposure interviews even longer, and have to go into multiple parts, especially for occupations where people have had a lot of work assignments over the years, like the building trades or mining. So we take that information, look at the general literature, both at the broader level once we see the distribution of diagnoses that are coming out, and then in terms of producing individual hygiene and medical assessments that are suitable for use as expert opinion evidence in legal proceedings if they pursue a WSIB claim. Filing Form 8s to launch WSIB claims where that's appropriate, and then sharing information back. And I'm going to talk about some of the examples of what that looks like. So here's an example of hazard mapping that we would do at one of those events to get the information from workers who, as they're there. Each of those little dots represents a specific exposure, and that's a map of the GE plant in Peterborough. OCAL started work on this particular historical exposure report about GE, and then that was taken up by Bob DiMatteo, who's a member of our board of directors, and Dale DiMatteo, who are both health and safety professionals. And they worked together with workers from the plant to create this large, certainly over 100 pages, between 100 and 150 page report on what happened in all the different areas of that plant, what all the different exposures were, this was taken up then by the WSIB to review previously denied occupational cancer and other occupational disease claims from the plant. And one of the, again, I'll come back to this again a couple more times about sometimes malign influence of epidemiology and simply concentrating on what epidemiologists feel able to say, feel able to investigate, what they can get published, and so on, and just the limitations of the methods to say that back in 2003, GE sponsored an epidemiological study within this plant that purported to show that there was no excess of cancers amongst that worker population, but there are, at this point, literally hundreds of recognized claims, many scores of lung cancer claims recognized. The exposure to asbestos in the plant was just insane in the worst areas at the worst times. And the detailed work done in this report was able to expand the available information about the areas of the plant in which that exposure occurred. So Sarah mentioned this report as well on the, pardon me, Ventra Plastics plant during the period where it was Pebra Plastics back in the 80s to 90s. And we're continuing to work on this project. We've been doing intake on individual workers using the remote methods since the beginning of the pandemic, and sort of sharpening our methods for that, and looking at what we can do on a site-specific basis in terms of further epidemiological work. So here's another thing that happens at the in-person intake clinics in terms of body mapping, showing the types of health conditions that people are complaining of when they arise, and it's put onto a body map at this location. You know, it's always a very interesting process, and as has also been mentioned, it also you know, can tell us things that you would not see just from reviewing the literature about what happens in this kind of a particular industry. So in terms of finding needles in a haystack, yeah, and I'm trying not to make a joke about rolling in the hay, but you know, the fact is, if you get down in there and start engaging with the people who actually know what's going on in the workplace, the needles find you on that body map. So, and that's true both historically in terms of the identification of occupational diseases, you know, within this century, even, I believe, we've had, for example, the discovery of popcorn lung, non-malignant lung disorder, purely by clinical means in the United States. Again, something that's not around so much that it would ever turn up in a large surveillance system covering entire, you know, the entire workforce. It's true both historically and in our work that happens. So if we look again at the asbestos-related cancer issue, is a particularly interesting one. By the mid-1920s, in the United States and Canada, it was not possible for an asbestos worker to get life insurance. That was a little factoid that stuck in my mind from the first time that I saw it in a book by Barry Castleman, and I followed it up a couple of years ago to find out, you know, what was the source of that? How did they arrive at that thinking? It would be something to do with the, you know, the actuaries at the insurance companies finding higher death rates, et cetera. and that this would tell us something really about some of the restrictive aspects of occupational disease adjudication that we were having. It was not until the 1980s that Ontario really reckoned with asbestos exposure, and that how much this had to do with, too demanding standards for scientific evidence, et cetera, rather than a common sense approach. And when I did follow it up, that wasn't what it illuminated. It illuminated that, in fact, it was much more common sense in terms of the life insurers. It traces back to a particular statistician with Prudential Insurance. And if you go back to the source document through a couple of other documents, all he is saying there is that, we must assume that this dust exposure is going to be harmful to workers in the same way that other dust exposures are. It was very much a practical approach. And at that same time that he was pushing his employer to refuse life insurance coverage to asbestos workers, the clinical approach was leading German occupational medicine specialists to the conclusion that asbestos caused lung cancer and asbestos caused mesothelioma. Again, decades before this was had broad acceptance in North America or in England. And in fact, by the 40s, Germany recognized both mesothelioma and asbestos-related lung cancer as compensable occupational diseases, even at a point in time where their official ideology was that Godwin's law alert. Their official ideology was that the ideal lapse in time between a worker's retirement and their death should be 0, because at the point that they retire, they're just a waste of space and no longer producing and contributing to society. So the German physicians were making that assessment in the 20s based on, again, clinical findings, pathology, where were the tumors located, what did that area of the lungs look like, and so on. Whereas modern epidemiology, as it arose in the post-war era, in response to, really to litigation and litigation fears and skepticism from industry advocates in the tobacco industry and all that, were seeking standards that would, guarantee the acceptance of their findings. And in those circles, it was being said there was no epidemiological evidence for asbestos-related lung cancer. Well into the 50s, and you could find people saying that, well into the 80s, and probably even still today somewhere. So that's a clear example where the clinical approach was able to arrive at conclusions, and at the very least, even the most narrow-minded epidemiologist has to say throws up the problems. So in our own work for McIntyre powder, for example, again, it popped out that we had a lot of ALS cases, which falls under the category of motor neuron disease. With Parkinson's and Alzheimer's, it was not as clear what we had because those are less rare. But because motor neuron disease is so rare, it seemed like we definitely had too many, even within our group of people who came forward. And then the same thing with sarcoidosis, idiopathic pulmonary fibrosis. So part of the result of being able to get out there with the anecdotal findings about ALS was in prodding the health records matching study that the OCRC did of McIntyre powder miners and non-McIntyre powder exposed miners, which has resulted in the WSIB recognizing Parkinson's disease as related to McIntyre powder exposure. And some of you may have seen in the news recently that apparently, although it's not yet been published in the Ontario Gazette, apparently Cabinet has last week added McIntyre powder to Schedule 3 in the regulation to the Workers' Comp Act as an occupational disease causing McIntyre powder. And that research and then later follow-up research using the ODSS at the OCRC has also shown that although the connection between McIntyre powder and motor neuron disease did not come through in the same way. In fact, a greater connection between working as a miner in general and motor neuron disease was found both in the health records matching study using the mining master file and in the ODSS study. So we are working on a number of cases on assessments on trying to, get further behind the published literature about environmental causes of motor neuron disease in order to provide assessments to those folks, and also in the Alzheimer's disease. With sarcoidosis, our team has already published a lit review on sarcoidosis as an occupational disease and has a case series report on McIntyre powder exposed miners in sarcoidosis that has been accepted for publication in the American Journal of Industrial Medicine. And we're working further on the idiopathic pulmonary fibrosis and cardiovascular disease issues, where I have in parentheses there manufactured rarity, because again, this was what we saw with asbestos. This is potentially and lung cancer, potentially what we see with cardiovascular disease. And a number of occupational exposures is that the methods of epidemiology just sort of pursued in isolation or not in a nuanced way can lead to the impression that, in fact, none of the instances of the disease are occupationally related. And then the salivary gland cancer issue, again, we're working on endocrine disruptors, reproductive effects. These are things that would never come up through simply looking at WSIB claims. But if you interview a bunch of workers at a plastics plant, and there are a ton of thyroid issues, a ton of reproductive issues, cancers related to endocrine disruption, et cetera, that really does leap out. So we're working hard to get in touch with the broader research in that field, talking to outside researchers, looking at all the things that Sarah mentioned in terms of really doing, advancing the research on those issues and doing the best we can for the particular workers that have come to us looking for answers. So I'll leave it there. Thanks.
Thanks, Dave. I think you had one more slide, but maybe you're, I'm not sure if you're utilizing it, but I did just want to point it out. And yeah, we have time for questions for both Dave, and then we have Giovanna with us and Sarah to take panel questions in general. So really, we tried to pull together the importance of science and evidence and including all levels, at the clinical level, at the medical level, at the epidemiological level, at the data level, and bring you this all together and draw a picture for you of the importance in our prevention of cancer. And we're going to talk a little bit about primary prevention that we get out of this later. Our work is really so unique nationally, and our partnership's so important. So please feel free to throw questions for our whole panel, and you folks, our panel speakers, welcome to turn your videos on, and we can have some discussions at people's will. So
I would just add for this slide, Kimberly, it's mostly self-explanatory, but under that use of the term cluster, I wanted to make sure that I said this today. This comes up sometimes, especially in discussions involving academics, that you should be very careful about the way you use that term and so on, because it has a particular meaning, and people should just keep that to themselves, really. keep it to a discussion with a reviewer number 2 when you're trying to publish an article, because if history shows us anything, it's that these sorts of technical distinctions are very much ill-used in that way. I mentioned the Peterborough GE study. It was the same thing in Elliott Lake with the uranium miners, of everyone, including the government, saying there was no excess of occupational cancers there. And then it turned out that the whole time they were looking at the evidence, and their own experts were reaching the opposite conclusions. But the Steelworkers Union only found out about it because some of their reps happened to be at a conference in France where a Ministry of Labor was presenting a paper on the topic. And the way that most people use that term cluster is the way that, in fact, the CDC, NIOSH, and everybody else uses it in all of their public communications. It's not an indication that one has confirmed a cluster related to a particular exposure or so on, in the way that it gets raised by these academics in this sort of discussion. People are able to make those distinctions, but to just jump in right off the bat and say, oh, hang on, you don't know that, blah, 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 is, to the people who are bringing these concerns forward, and frankly, to me and lots of other people, a sign that, your head is not in the right space to do a proper, open-minded investigation of it, that, you're going to pull out all the skeptical stops, which has an appropriate methodological place before stating conclusions, but is not what you should be telling people at the outset of such an enterprise. It's disrespectful.
Yeah, thanks. And it's funny how words matter, and then words get in the way. At the same time, I think colleagues and I were chatting about the same thing happening with airborne, aerosolized, and becoming, versus droplet with COVID, and cluster being a problem when it comes to just talking about, work relatedness of illness. So yeah, thanks for bringing that. Thanks for bringing that to our attention. You can stop sharing if you want, Dave, and we can take questions. So please feel free to unmute for our panel of experts in EPI and from the Occupational Cancer Research Center and from OCAL, showing how all these partners work together. And it's interesting. I mentioned at the outset that most of OCAL's work is this clinical work, looking at work relatedness of illness. But as we've indicated today, it's shifted quite a bit to these larger investigations as well. We do work on individual patient files and look at, evidence-based medical interdisciplinary opinion on whether, a disease onset is clinical, is work-related, but it has also shifted to these larger investigation projects as well. And there was an earlier question that I'll bring back about, the path to determining if your cancer is work-related, and maybe we've clarified that a little bit in the presentations, but maybe around the larger projects, and just wondered if anybody wants to chat about that, because I think a lot of people realize, family physicians, do people even ask? It's one of the things we're working on, the Oct-Disease Action Plan, is, do people even ask how you got cancer? You're working on treating it, and you might, that's where your focus is. But that becomes a hiccup, to a barrier to later on. And I often say that all occupational hygiene education and physician education, should have this retrospective exposure assessment piece and to it that isn't part of the regular training. So I don't know if anybody has comments on that path to how do you know if and a cancer is occupational, which was one of the questions from our guests.
Maybe I'll just add something to that question.
Yeah.
Yeah, so I think that is one of the challenges, especially when we're looking at rare cancers and we don't really know much about them in general. For mesothelioma, for example, we're seeing results in a large surveillance system that are very similar to what's well known about asbestos exposure and mesothelioma. So I think in that sense, we can say, okay, this, really does fit the story, or the narrative. But then we see other rare cancers where we don't know how to really interpret the findings, and we have to really be careful how we say this because we don't have exposure data in the surveillance system. We do try to use some of the CAREX information and other ways of trying to include exposure information so that we could really understand how these rare cancers are related to occupation. But I think that's an important point because on our end, we've got this large surveillance system where we don't have exposure data. We do have the challenge of interpreting multiple comparisons where we're looking at so many different occupation and industry groups. So it's something that we talk about often when we're publishing or trying to really present our findings in a meaningful way. For some cancers, it may be easier to identify given the previous evidence available, but also given what we know or what others have done. But in some cases, that is a very important challenge that we're trying to really navigate, but also be careful with how we interpret the data we have, and if it's something that hasn't been seen in other studies at all, or something that is emerging. And I think we try to present our findings in a fair manner where we do publish it on our websites, and that way it may not align with some of the things that other studies have found, but at the same time we want to be transparent with what we see in the surveillance system.
Great. Anybody have any other things to add, or would anybody like to unmute and join us with questions? Sarah, go ahead.
I have a bit of an addition, but yes, to add to Giovanna's point, I do think it's a really, really difficult process. And I think speaking to some of what Dave mentioned as well, the determining whether a disease is occupation related, especially through the workers' compensation system, is particularly interesting because it's a process that is both legal and also scientific. And so there are these processes where we kind of see these two fields that need to blend and are not normally used to blending. And I think this happens also in the court system in general, but we see issues like, for example, what Dave was speaking to, where there's scientific criteria that are sometimes used in a legal fashion when really on a scientific base, for the scientific interpretation of them, they're actually not, it's not necessarily appropriate to use them in a specific way legally where they're used as a cutoff. So an example that I could give for that might be that you have, for example, scientific or statistical significance, where I was saying, the literature might show that there's statistically significant results related to a specific occupation or exposure and a disease outcome. But then for other results that maybe are actually very precise and show that there's a high magnitude and a precise estimate, but that it's not necessarily statistically significant, it might be discarded and not considered. So I think that I just wanted to mention that there's this kind of play in the determination of how we actually determine occupation relatedness that is both legal and scientific, and becomes very complicated because of also the one slide that I mentioned, where in the systems, we're also trying to apply tools that are maybe how do I say this? I guess the general population level. So like epidemiology, which is a field that's looking at a population level, do we see an association between specific exposures, or an occupation level, like with the ODSS that Giovanna had showed us with occupations or industries, and the association between that and an illness. And so that's at the population level. But then we also are trying to say, okay, at the population level, we see this specific trend. How do we apply that at the individual level? So for one worker whose workplace relatedness is in question. So this question that you've raised is actually one that I think is continues to be a true struggle for all of us. But I think we have a long way to go in recognizing when and where to apply epidemiology in this process, and where it's actually not helpful to apply epidemiology, and where we might need more triangulation, like with these other sources, of actually looking at the exposure side and also studies that look at the mechanistic ways that, like, how does the disease actually happen in the body with a specific exposure, and how that disease is manifested in our bodies. So there's groups, interestingly, like the International Agency for Research on Cancer, that does do this work to try to look at kind of scans across not only the epidemiologic evidence, but also on a, like, even the animal scale of, if we look at exposing animals to a specific exposure and looking at disease, what does that look like? And then how do we apply that to humans? And then also this other side related to, yeah, so the mechanistic studies, the animal toxicity studies, as well as epidemiology. So kind of trying to do a broader scale look at this. So there's a lot of different methods that are brought into one space to try to determine occupation relatedness. And I don't think that we've yet, I think we still have a long way to go, but we're learning. And I think there's really good questions being asked around when are certain methods appropriate and when are others better to use. So all that to say, I'll leave it there. That's
Thanks,
a great question.
Honestly, let us figure it out for you, right? So you know, if Lisa is mentioning, you know, look, if you have been exposed to carcinogens at work, and your safety data sheets can sometimes give information for that, or if you know you're working in some of the things that Giovanna presented and Dave talked about, if you're working in industry or construction, or, you know, and you develop 1 in 5 of your cancer is work related. Help you figure that out. So again, 1 in 5 are work related. So, you know, make sure if you think you had exposure at work, and the other is the multiple exposures, you know, that can be difficult. It's not just, you know, it's not as simple, unfortunately, as X equals Y. And you can have, you know, synergistic effects and multiplicative effects with various exposures in different jobs. So yeah, if you think and you've had exposure at all with the work that you do, definitely put in a claim and let us help you figure that out as an interdisciplinary team. Any other questions for our panel of speakers today? I want to conclude with, again, thanking our speakers and all of what we do also at OCal is aside from all this beautiful clinical work and these large cluster projects on this World Cancer Day, is try to provide tools again in the prevention of these cancers. So I did want to point out one in particular where we're looking for your help. And a few others, because, you know, how do you prevent cancers? Well, you reduce exposures, right? And you control exposures at the workplace. So one call to action is, if you know everybody, even if there are no construction workers with us today, we are trying to run a silica control tool pilot right now, and looking for construction industry to apply with a partnership with the BC Construction Safety Alliance and the CCOHS and the Infrastructure Health and Safety Association to get, you know, some construction access to this silica control tool and pilot it in Ontario. So please do visit or send friends who are working in construction, whether they're small, medium, or large. We're looking for participants around the province. We also have an occupational exposure limit adjustment tool where, you know, if you're working on irregular shifts, and coming soon will be the second phase of this. This one is compliance-based, where you should be exposed to fewer chemicals than what you're exposed to you know, if you're working a longer shift or longer hours than normal. So instead of looking at the regular exposure limits, we want to help you see that can be reduced. We have a whole website section on work-related cancer where you can see our work on our website with videos from last year's presentation, as well as a new PDF, thanks to on our Is Your Cancer Work Related in an infographic style. So I did just want to point you to that. Go check that out. Kevin, we also have our Prevent Off Disease and the Asbestos Management in Kansas. You'll receive this slide later where you can click through. And Kevin, I don't know if you want to talk about, we also have coming, as I mentioned, a worker exposure history tool where you should be tracking, just like your CV, all of your work your work exposure history, so that you can answer that question yourself. What were you exposed to? And some control and exposure banding tools, and etc. with the eChat tool, for example. So I don't know, Kevin, if we had a minute for you to talk about the diesel calculator that's up and coming. We have a minute or so, if that works.
And Kimberly, I'm sorry to interrupt. I just wanted to make sure that we were unable to see the slides. Were you sharing a slide? I didn't want to interrupt you. I was afraid. Okay.
Oh, I appreciate that. I was sorry, I was, but it didn't work. So I apologize for that. Probably because got too much going on my screen here. But it'll be presented with the video at the when we post everything. I will present the slide with all of the tools and resources. That's too bad. Sorry.
Perfect.
Thanks, Bonnie. And I did want to mention, I'll throw in the chat not sure if you're here, Kevin, the Octadisease Stats website as well from the Occupational Cancer Research Center that Giovanna was speaking about. So we'll throw that in the chat window here as well. And I don't know if Bonnie, if you put up the survey that we so importantly are looking for and wanted to promote our RSI Day sessions, which are our next webinar series coming up on the Fridays. Oh, thanks, Bonnie. So I put the Octadisease Stats website up, shared between OCRC and CCOHS. You'll be getting slides and video of today's presentations in about a week or so. And just wanted you to have a lovely day. And thanks for joining us on this World Cancer Day. And please help us prevent cancers, rare or not so rare, as with our silica control tool and some of our diesel. So I think Kevin's not here. I'm so sorry. He was gonna say a quick hi about the diesel exhaust calculator, but it's up and coming. Stay tuned. So watch for all our prevention tools. Thanks so much, Sarah and Giovanna and Dave. And
thanks, everybody.
Thank you. Thanks for inviting us to speak today.
Take care.
Bye, everybody.
Bye, everyone. Thank you.
Take care, everybody.